up towards the chest. In order to test flexion, one must assure that the pelvis does not rotate in order to contribute to the amount of flexion at the hip. If the hand is kept under the lumbosacral spine, any pelvic rotation can be assessed. Normal flexion is approximately 135 degrees. Rotation. Rotation of the hip should be tested both in extension and in flexion with the leg in the neutral position. It is essential that one does not use the foot in order to measure degrees of rotation, because there is rotation alone at the foot and ankle, and this does not involve any movement of the hip. Internal rotation is normally about 35 degrees and external rotation about 45 degrees. Extension. With the patient lying prone, stabilize the pelvis against the examining table by placing the forearm across the posterior superior iliac spines. Have the patient bend the knee slightly to eliminate hamstring contribution to extension, and then have the patient lift the thigh off the table. Normal range of extension is approximately 10 degrees. It is also possible to assess ranges of motion that are frequently done in activities of daily living, and their loss may limit functional abilities. Flexion and adduction. This is the ability to cross one thigh over the other thigh in a sitting position. Flexion, abduction, and external rotation. This is the ability to place the lateral side of the ipsilateral foot on the opposite knee. Extension. This motion can be assessed by the ability of the patient to get off the chair with his arms crossed on his chest while keeping his back straight. As discussed in the introduction to the physical examination of the musculoskeletal system, if active motion is limited, it is also necessary to examine passive range of motion. That is, the motion performed by the examiner without the aid of the patient. To do a proper assessment of passive range of motion requires a completely relaxed and cooperative patient, and a brief description of the purpose and nature of the examination to the patient will allay their fears and aid in their cooperation. If from the history or earlier parts of the examination one expects pain to be produced, the patient should be instructed to tell the examiner when they begin to experience pain. Gentleness by the examiner will assist patient cooperation, and if the examiner feels that a certain motion will cause pain, this should be examined last. If the patient complains of pain, always ask the patient to describe its location. Although the examiner is testing hip motion, the pain may come from the back or knee, and hence pathology other than in the hip must be sought. The point at which pain begins and the maximum passive motion achieved should be documented by means of a goniometer. Flexion. The patient lies in the supine position, and the line between the anterior superior iliac spines should be perpendicular to the trunk. The leg should be in a neutral position, that is, no abduction, adduction, internal or external rotation. Place one hand under the lumbar spine, and with the other hand allow the knee to bend and flex the thigh towards the chest. The hand under the lumbosacral spine will also be able to detect any pelvic rotation, which is obviously not part of true hip flexion. Abduction. The ability to abduct the hip is extremely important for activities such as perineal care and sexual intercourse, especially in the female. The patient is lying supine, and again the legs are in the neutral position. Stabilize the pelvis with the forearm across the anterior superior iliac spines, and abduct the leg from the neutral position, grasping the leg about the ankle. Some patients are sensitive to pressure about the ankle, and hence it is necessary for the grasp to be gentle. Again, the normal range of abduction is 45 degrees. A record of the ability to abduct the hip can also be kept by serial measurements of the intermalleolar distance with the hips maximally abducted. Abduction. The position is identical for testing abduction. Again, the pelvis must be stabilized and the leg crossed over the opposite leg. Since excessive soft tissue of the thigh may impede adduction, start with the opposite extremity in abduction, then adduct the extremity being tested. The normal is approximately 20 degrees. Rotation. Rotation of the hip must be tested in both extension and flexion, since limitation of rotation may vary in each of these positions. Rotation in extension. The patient lies supine. In the neutral position, the patella should point straight up to the ceiling. Grasp the tibia, then internally rotate the leg towards the opposite extremity. The midpoint of the patella must be used for measurement, as you cannot use the foot because there is rotation at the foot and ankle independent of hip rotation. External rotation is assessed by rotating the limb away from the opposite leg. Alternatively, rotation in extension can be assessed with the patient lying prone and the knee bent to 90 degrees. The tibia can be used as a lever and pointer, but remember that the motion being imparted to the hip and femur can be confusing. Pointing the tibia towards the other extremity causes external rotation of the hip and femur, and pointing it away from the opposite extremity imparts internal rotation. Rotation in flexion. With the patient lying supine, flex the hip and knee on the side being tested to 90 degrees. Assuring that there is no excessive medial or lateral laxity of the knee, the tibia can be used again as a lever to rotate the hip. By pushing the tibia towards the opposite extremity, the examiner is externally rotating the hip, and the number of degrees of rotation of the hip can be assessed by measuring the angle between the neutral position of the tibia and the end position. Likewise, internal rotation is tested by pulling the tibia away from the opposite extremity and measuring the degrees of rotation. These motions about the hip are initially confusing when learning to do the musculoskeletal examination. You can always confirm on yourself by palpating your own greater trochanter and performing the motion. Remember, when the trochanter moves posteriorly, the hip is externally rotating, and conversely, internally rotating when the greater trochanter moves anteriorly. Rotation in flexion can also be done in the sitting position, with the knee bent to 90 degrees over the examining table, and using the tibia again as a lever to rotate the hip. Neurological examination. The detailed neurological examination of the hip region is covered in the video program on the physical examination of the lumbar spine and the neurological examination of the lower extremities, but would normally be performed at this point in time in the examination of the hip. The patient should keep the trunk perpendicular to the floor, as excessive leaning to the side of the supporting leg may negate a positive test. The examiner then observes what happens to the iliac crest on the side that is non-weight bearing. If the gluteus medius is functioning normally on the weight bearing side, the pelvis on the contralateral or non-weight bearing side will remain horizontal or rise above the horizontal. This would be considered a negative Trendelenburg sign. If the gluteus medius on the weight bearing side is not functioning normally, then the iliac crest on the non-supported side will drop below the horizontal, indicating a positive Trendelenburg test on the right side. Thomas test. It would seem that a patient with a fixed flexion deformity of the hip would not be able to put the corresponding foot on the ground or lie flat in bed. This is obviously not the case, and by increasing the lordosis of the lumbar spine, the patient is able to compensate for a fixed flexion deformity of the hip. The Thomas test is designed to detect and measure the magnitude of a fixed flexion deformity. In order to examine the right hip for a possible fixed flexion deformity, the patient lies supine and the examiner stands on the patient's right side. The examiner places his flat hand under the mid-lumbar spine. The patient's left leg is then flexed towards the chest until the lumbar spine is flattened against the examiner's hand. The patient then holds the left knee in order to maintain this position. The examiner then notes whether the right leg is lying flat on the examining table. If it is not, the angle of elevation can be measured and recorded as the amount of fixed flexion deformity of the hip. Two important points have to be considered when performing this test. 1. If there is a corresponding fixed flexion deformity of the ipsilateral knee, then obviously the thigh will not lie flat on the examining table. In this case, the leg being tested must be abducted to the side so that the lower leg is clear of the examining table, and thus the component caused by the fixed flexion deformity of the knee is eliminated. 2. If the flexion deformity of the hip is great, then as the opposite leg is brought up towards the chest, the leg with the hip flexion deformity may be suspended in the air, and this may be very painful for the patient. In this case, it is best to flex both thighs to the chest, and after stabilizing the spine and the pelvis, gradually lower the affected leg to the point of stopping and measure the magnitude of the fixed flexion deformity. Length either in the femur or the tibia. Apparent discrepancy is due to a fixed obliquity of the pelvis or a fixed flexion, abduction, or adduction contracture of the hip. True shortening. It is first necessary to measure true leg length. The patient lies supine and the pelvis should be horizontal across the examining table. Both legs should be in the neutral position or in a position perpendicular to the plane of the anterior superior iliac spines. A tape measure is then placed at the anterior superior iliac spine, and the distance to the tip of the lateral malleolus is measured. Many authors suggest measuring to the medial malleolus, but I find that excessive thigh girth or atrophy can influence the measurement. The measurement for each extremity is performed identically and recorded. If a true discrepancy is found, the examiner can then assess whether the discrepancy lies in the tibia or the femur. The patient, again lying supine, flexes the knees to approximately 90 degrees. The examiner then observes from the side. If one knee projects further anteriorly than the other, then the femur on that side is longer. If one knee is higher than the other, then the tibia on that side is longer. Obviously, this is an approximate assessment only, and it is necessary to obtain a radiological scanogram to more accurately measure bony length. Length discrepancy if there was no true leg length discrepancy. Ober test. The patient lies on the side opposite to that being tested. The examiner then abducts the thigh as far as possible while keeping neutral rotation, flexion, and extension of the hip. The knee is flexed to 90 degrees. The leg is then lowered towards the opposite leg, and if the medial aspects of the knees contact each other, then the Ober test is negative. If the thigh remains elevated, that is, does not contact the opposite leg, then the Ober test is positive, and this signifies a tightness or contracture of the fascia lata or iliotibial band. Such a positive test may be found in myelomeningocele or polio. This completes the detailed examination of the adult hip, but remember that related areas such as the lumbar spine, abdomen, knee, and thigh must be included in the examination of the hip.